Welcome to the Low Carb MD Podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD Podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Hello and welcome back to the Low Carb MD Podcast. Tro, good to see you again, man.
It's good to see you, man. We're gonna. Well, how you been? Let's
We're gonna learn stuff.
Yeah.
Peter Ballerstedt wrote me into giving a talk to a bunch of ranchers down in Tucson, which is like a 4-hour drive for me. So might be a little car lagged driving back this morning, but yeah, it was awesome. Awesome time. Great people, super smart, and when they hear they're not killing everyone by growing cattle, they were really a great audience, really smart people asking a lot of great questions. And I was really impressed. One thing I just want to people who are listening is these people, they had hours of lectures of how to preserve the land, how to treat the animals well, it was really an amazing thing to see how much time and effort and science goes into this. Like, it's not just cows roaming in the field. Like, they move them, then the huge move is to regenerative agriculture. And that's what like most of the topics were on. It's pretty cool to see how you see the land, what it was like before and what it looks like now. These people taking pictures, you go, wow, it's pretty impressive what they can do with the technology and just showing some interest in preserving things, so it's not like they're just tearing up all the land. Anyways, that's what I did this week.
That's awesome, man. What are all those nice people doing bringing you to talk?
Peter's trying to merge. I mean, it's a perfect thing. It's his mission of love. He does it on his own dime, by the way, and he goes in and is trying to bring the ranchers and the low carb people together, so we all understand, and so ranchers have a better idea of metabolic health, and the interest in metabolic health is really taking off. So for them to hear it, it was just encouraging to them that and a lot of them are struggling with obesity, diabetes, and all that because they bought into the food pyramid stuff, and they're eating a bunch of grains and cereals and toast, and like when it's just amazing because they would say, well, we eat our oatmeal with like the packaged oatmeal every morning. I'm like, you guys have eggs and everything right there. What are you doing? Well, we thought it was bad for us. It's amazing. It's amazing. So it was pretty cool. It's cool that Ballerstedt's bringing all these groups together and just trying to really, mend fences and get people to see each other's visions.
Yeah, we gotta definitely share that once that goes live. And I'm excited today. When we've been talking about on the show preventative health, we've been talking about metabolic health, we've been talking about breaking outside of the system, and that insurance is sort of thinking 15 years behind. And so I'm super excited about our guest today. Somebody who also shares the passion of prevention, which I think is really underappreciated in our modern sort of assurance/occurrence-based system. And today we have the pleasure of having Dr. Vikash Modi. He is a family medicine doctor, so he's one of us. But he's got a strong passion in prevention, and he works with a company called Prenuvo, which is a company that's leading, basically democratizing, bringing full body MRIs to the population. And he started his career at Emory in neuroscience. He did medical school at the Medical College of Georgia. He did his family medicine residency at the Medical College of Georgia. And he's been with Prenuvo for about a year now. So excited to learn everything about radiology, about prevention, about how what does the frontier hold. And I'm excited to hear about this because Brian, you and I know that it took 10 years too late to get insurance companies to approve breast MRIs, prostate MRIs for cancer prevention. And finally, they're coming a little bit on board. But it's too long and too late. So anyway, Dr. Modi, pleasure to have you. Thank you for coming on, and hopefully you can start by maybe just telling us how you got into medicine, what your passions are. So maybe we could start there.
Absolutely. Well, thanks again, Tro and Brian, for having me on. This is super exciting. I love hearing about different experiences in preventative medicine, and so Brian, the story you just told about talking to a bunch of ranchers takes me back to like my first gig coming out of residency. So I can start there that I, grew up in a small town in Georgia and primary care, preventive medicine just wasn't really a great big thing on the radar. And I would see people in my community getting ill. My father, experienced cardiovascular disease at a really young age. And so I was watching all that from the bedside as I was going into sort of the medical profession and saying, we have to do better as a profession, as a community, in taking care of ourselves proactively. And, I would drive down my neighborhood and see 10 different fast food restaurants, and we couldn't get, fresh produce for 100 miles, which makes no sense in small town Georgia. We should have, farms and things everywhere. So, it sort of struck me at an early age, and I got really interested in lifestyle medicine. I would be the resident who was asking people what they had for dinner and breakfast, and it would piss off all my attendings. But that's sort of the thing you got to do, right? Like you got to kind of do the thing that you're passionate about. So I found myself doing that to the point that I got recruited to open a lifestyle medicine practice happily in my hometown, coming straight out of residency. And I had this wonderful group of mentors and investors coming down from Kentucky who wanted to open this practice with me. So we started this little clinic, and it was a one-stop shop for primary care, urgent care, lifestyle medicine. And I was doing nutrition classes 3 days a week myself. I was going to the gym and working out with my patients a couple of days a week. And we started doing, and this is where I kind of got introduced to the idea of new technology. We started doing, at the time, really advanced, these were 10, 15 years ago, lipoproteins and inflammatory markers way before they were really kind of mainstream. And we started doing, echocardiograms and these cardiometabolic exercise tests called CPET testing in our clinics. And it was just sort of like so out of the realm of like what everybody else in our community was already doing. And I would try and work with the specialists, and they were kind of scratching their heads saying, what does this test even indicate? So at some point I sort of took over the primary care for the cardiology patients and just turned the cardiologists into technicians. Hey, I need you to do a bypass or a stent. I got everything else. I'll handle the medicines and the lifestyle stuff. So that was my sort of humble beginnings in primary care. And then I spent the last 10 years sort of working with a big healthcare system in Georgia, developing primary care programs, preventive medicine programs, working with different employers. So that takes me back to the cattle rancher story, that one of my first patients was a cattle rancher out of Kentucky. And, we worked with him to develop sort of a really personalized nutrition plan, because he was, sort of so afraid of his own products that he was completely vegetarian. And we got to the point of like understanding with him that he needed some protein, and some of his own product, his rancher product, was actually healthy and safe for him. And so we were able to build him a personalized nutrition plan that actually worked really well for his cardiovascular and cancer risk factors.
Wow, that's pretty amazing. And that's an amazing thing. These guys have access, and like you're saying, small town USA. A lot of them are on the border in Texas and Mexico, and they go, look, they're telling me about their communities and what they see, the morbidly obese, 9-year-olds, 12-year-olds, their teeth are falling out. They're drinking Mountain Dew and Gatorade and all this stuff. And it's like, everyone's kind of helpless about the problem. They go, gosh, we have all this good food here, and they're eating absolute garbage. Like, so, one of the ladies was saying she goes to the grocery store and sees what everyone has in their
shopping carts.
Shopping carts. And she says, oh my gosh, like if people knew, they would make a change, but no one educates them, or no one asks those questions that your attendings don't like. And Tro and I were the same thing. We were in the same situation. Like, why are you giving all these guys sugar, and then you're giving them insulin, and why don't we try to work on that problem? And so it's amazing. Yeah.
I'll do you one better. Like I remember being in my diabetes lectures, and then we would be eating donuts while we're learning about diabetes and insulin resistance.
Course, yeah.
And I'm just shaking my head saying, we're not even following our own attention here, our own prescriptions. So it became a big passion of mine starting out, and that carried me through the last, 10 years of my career. And then, that kind of brings me to the current present day, that here I am practicing in Georgia. And, the idea of early cancer detection really hit my radar the last few years with new technologies emerging. There was this company, multi-cancer early detection, with like Grail from Gallery.
Yeah.
And so that test started to show up on my radar. Patients were coming to me asking about these things. And so I had to sort of, do the catch up, educate myself piece. And then because I knew about that, I also started to look into the imaging options. And there were some local MRI facilities here in Atlanta that were offering whole body MRIs. And so I got super curious, and I went and visited to see what they're doing and understand their processes. And then the timing just coalesced that Prenuvo, this kind of newer company, this tech company, was coming to the Atlanta area, and they were setting up a practice. So I reached out to them just to sort of, try to work out like an ability to work with them. And I really kind of just sort of clicked with their CEO. a fellow named Andrew Lacey out of California. And when I shared sort of my vision for preventative medicine and proactive medicine with him, he really, jumped in hook, line, and sinker and said, this is really what we need to start looking at as a company moving forward, that we can't just be an imaging center. We need to sort of be this transformative power in the world of preventative medicine. And if we start to implement the scan results in conjunction with things like what you're doing in your practices with biomarkers and genetic markers, things that you guys know are very effective pieces of the puzzle, we can now build this full-fledged roadmap for each of our patients to get really proactive.
So like you're a family medicine guy, right? And to what degree, in your family medicine career, did you use sort of imaging for prevention, and how difficult did you find it? I hinted at, some of the modalities that are now quote unquote approved by the USPSTF or some of our medical organizations, but are still very challenging to get for patients. It's
absolutely
like getting a prostate MRI for a male. It's like you need, it's kind of ridiculous.
You got to get an act of Congress passed to get some of these things approved. And that's where I was finding myself trying to order less invasive testing for my patients. If I knew they had dense breast tissue, I'd try and get them the breast MRI, especially if you can put them into sort of the different rating systems or the different score assessments, and you show that they've got a greater than 20% lifetime risk of breast cancer. It actually should automatically qualify them for a breast MRI, and yet the insurance companies are still pushing back, which means the patients just kind of stuff wringing their hands saying, well, Dr. Modi, you're telling me this is the best test for me, but then these insurance companies are telling me I can't get that test. And I don't understand the disconnect. Like if my doctor says it's good for me, why can't I pursue this? So that part, obviously, we all get really frustrated with these hurdles that we have to go through. And that would be me on a Friday night spending 2 hours on the phone with, a representative from X, Y, or Z insurance company until I could finally make my case and get these things approved. So obviously that frustration builds in any provider, in any family practice or internal medicine practice, that you're building that, but you're doing the best thing you can for your patients, so you stick with it.
Yeah, their bet is we're going to give up and say, forget it. We're not going through this. Like prior authorization after you work a 14-hour day, you're like, you know what? I want to go home. I'm done.
Absolutely.
Yeah, it's so hard.
So yeah, the number of times my wife would listen to me just sit on hold during dinner until I can get a representative on the phone. She would smack me around a little bit and say, you gotta, put the phone down. I said, no, I've been on hold for half an hour. Just let me see this one through.
Yeah, my staff they were just teasing me because they were saying you were so brutal with this one, because I was trying to get something approved. This guy needed a study done, and this doctor was just blackballing, not letting it go out. I go, can I have your license number? I'm going to put it in my chart in case something happens to this patient. She came hung up on me.
Ooh,
I go, can I put you, because you're making a medical decision. I want to put your life, because they hide behind this organization and they deny stuff left and right. They get paid to deny things. And so the frustration. So I hopefully people listening can get a flavor of what we go through.
Yeah, absolutely. So, but yeah, some of the other imaging, like I was a really early adopter of coronary calcium scans when those first became sort of available in our community. And again, because cardiovascular disease was so near and dear to me with my father's health, I really started looking into that science. And then as CT angiography became more available, I started pivoting a little bit more towards those modalities. Mm-hmm. Same thing. I was ordering, ultrasounds and echocardiograms and things on patients that it didn't make a lot of sense to maybe the cardiologist. But if I did one of my cardiopulmonary exercise tests that showed some unusual microvascular changes, then to me, taking those next steps with angiography or echocardiograms made a lot more sense. But on paper, this patient's cholesterol looks okay, their blood pressure looks okay. They're just kind of slipping through the cracks. Mm-hmm. And so, to put that patient in front of a cardiologist and then essentially get that patient into either intervention, whether it's medications or procedures, and years before they actually had actual damage, was just such a powerful thing for my patient population. And I was, as Repatha and some of those class of medications came through, the Evolocumabs, that I was an early adopter in the primary care setting to implementing those medications for my patients. And I would have cardiologists still sticking to their plain old statins from 30 years ago. And I'd be, scratching my head saying, guys, why aren't we starting to implement these newer technologies, these newer treatments that are coming around? So it just takes time. The traditional medical care establishment just takes a lot of time to adopt we're looking for evidence-based guidelines and massive case-controlled studies, and we need 5 to 10 years of peer-reviewed journals on a topic before we can adopt it. But we're seeing things on the ground floor that we can see are helping our patients immediately, and we're just getting obstructed by things like the cost of the technology. So again, full circle back to Prenuvo. Here they are coming to Atlanta. They're going to be offering this technology, which we're going to debate the cost of this thing. But when I looked at the cost I was having my patients pay for an insurance covered procedure versus how much they were charging for a whole body MRI at Prenuvo, I was saying, what are we arguing about here, guys? People are spending this much money on their insurance covered procedures and getting a fraction of the information that this scan is going to be able to show my patients. So I kind of got through the cost barrier pretty quickly with that one mentally. And then when you really get your hands on these reports, it's such an amazing thing because you truly get this full blueprint of a person's body. It starts to pave the way for a roadmap. And I started pulling these magic tricks out of my hat where I could tell a patient, from this scan, I think I can imagine that you probably don't sleep very well and you have a deviated septum, and let's think about getting you a sleep study. And guess what? 6 months later, now that you're on the CPAP device, your energy is better, your mental clarity is improving, and your blood pressure is coming down. Let's start titrating down that blood pressure medication. It was a tremendous shift in how I was able to tackle my patient's health, because when you show them that black and white picture in front of them, it's really hard to hide behind that.
Yeah, I think one of the things that is a worry when it comes to imaging is, the false positives. So,
Sure.
Just for the listener, the initial knee-jerk thought may be, wow, here's a full body MRI, or here is a, clearly CTA, or here's a heart flow CTA, or here's a CAC. You get these tests and sometimes you have to worry about false negatives. So like if you're young and you get a CAC or a CTA, the expectation should be that you're not going to find anything. So it really shouldn't give you a false sense of certainty. But alternatively, you may find something that is just completely incidental. And, I can't tell you how many pulmonary nodules we catch on CACs and CCTAs that we order. So you have to deal with those. You have to deal with this sort of
renal cysts, hepatic cysts.
Oh, totally.
Yeah. So that's a big one that where people, one of my nightmares early on, I had a guy that came in and he had imaging for something else, and I go, you got a renal, a cyst. And I go, it's a renal cyst. Don't worry about it. Because I want to see a nephrologist. Okay, nephrologist, don't worry about it. He went to another guy, said, don't worry about it. Then he found some guy in LA, goes, I'll stick a needle in it. And they ruptured his renal artery, and the guy was in the ICU for 8 days for a benign cyst, So sometimes those are the issues. But on the other coin, a friend of mine was having some health issues. He ended up getting an MRI as part of a workup for something totally different. And they found a huge aneurysm that was eroding into his sinus that it could have killed him possibly down the road. And you go, wow, that was like something we never would have known was there. He didn't have any symptoms in that area.
We do. We're, at least internally, we've sort of started to convert our vocabulary around incidentals and incidentalomas. And to our radiologists and to our preventative medicine doctors, it's sort of like what's high acuity and what's low acuity, and what's going to actually harm your patient. So we use a grading system called the OncoRads, which is sort of like what you would consider with PI-RADS for prostate, BI-RADS for breast. We've actually developed with our partners in Italy and England a system called OncoRads, which really helps us assess the severity or the urgency of a finding that we'll see for malignancy. And now, alongside of that one's actually been a published paper. There's literature that's supporting the use of OncoRads as a scoring system for whole body MRIs. We're now developing a second scoring system called the CSD, which is clinically significant diagnosis or disease. And again, we can now confer a rating score to a finding. That 1 centimeter pulmonary nodule might be a CSD score of 2, which will confer follow-up in 12 months unless you have a history of smoking, then get a dedicated CT scan. And I like to use that as an example because once we see something really high risk, we're going to pivot to traditional imaging modalities. That, a whole body MRI that does not use contrast is not the preferred or diagnostic step when you're trying to make a true diagnosis. That a lot of times when we find something, it's going to require an additional step to confirm the diagnosis. So again, when you think about what screening exams are, you have a screening mammogram. A screening mammogram very rarely ends up in being, diagnosed breast cancer. You end up getting the diagnostic mammogram, and then you get tissue pathology, and then you get the final diagnosis. So in a way, we're sort of just falling into that cadence, but we're also circumventing some of those unnecessary early steps, because when you have a very obvious lung nodule or lung mass, we can sometimes skip the line instead of wasting time with CT scans and go straight into tissue biopsy. So I'm happy to report that we have some numbers now coming out of our Polaris study from the past year in Vancouver that showed that out of Prenuvo studies, 56.4 of our findings, 56.4% resulted in true biopsies and true positive findings out of our scans. Now, that number by itself may not look very impressive, but when you compare that to something like PSA, which gives you a 25% true biopsy rate, or a screening mammogram, which gives you a 30% true biopsy rate, we like to say that 56.4 is actually pretty well standing up against the traditional historical screening modalities. So the lower acuity findings is really where I fit in, is that I'm working with our team internally to give our patients a little more communication about the risk or harm of just leaving that renal cyst alone, or leaving that hepatic hemangioma alone, and saying, we're just going to monitor that with maybe imaging within 1 to 2 years. We don't need to go sticking everything with a needle, especially if we have partners like you guys in the community who are taking care of these patients, who have liver enzymes and renal function tests showing good health. And you can recheck those things, periodically every 6 months or 3 months in between, then that's a very small incremental price for us detecting something on the screening test. And that would prevent us from going to these, the fellow that you mentioned who finally found a fifth doctor to finally do the biopsy. When patients get something in their head, it's like Inception. They're not going to let it go no matter what I say. I could do a biopsy and they'll say, well, you still missed it. And guess what?
Yeah, that's a hard part. Yeah.
And they can point to things like prostate biopsies and still prove that point, that, oh, my buddy got, a 12 needle prostate biopsy, and they still missed his cancer, right? Mm-hmm. So there's certainly going to be contradictory stories out there, but at the end of the day, we find that our studies are best matched with really great communicators on the primary care side, and we want to be able to work with our physicians on the primary care side, our providers on the primary care side, to say, listen, your patients best. We think that this lung nodule looks really low risk. From the history that we have, we would not recommend pursuing this thing. But now you look at your data, you look at this patient's history. If you decide something differently, then that's your choice. But if you support what we're saying, then this patient just now knows about something and can move on with their life. And knowing about something is not always a bad thing. It's not a bad thing to know that you have a pancreatic cyst, because if something starts to happen with your insulin or your pancreatic enzymes, you know exactly where to focus your attention. You don't have to go wondering, what could this be? You say, I had that Prenuvo scan 5 years ago that showed a 4 millimeter cyst in my pancreas. Maybe we should go checking that out again and see if it's grown or changed.
One of the things I'd like to sort of harp in on is, the medical legal landscape, and also patient sort of anxiety. And then, one of the things they taught all of us in med school is the idea of finding an incidental, it's the issue with imaging or labs is not that it comes back positive, right? That's not the harm. Maybe there's a bit of harm because it causes anxiety. The harm comes when that anxiety or that bit of information leads the patient and the doctor to get an intervention that was not necessary. And so that's the harm, right? The harm is not being able to sit on your hands. And I've long been a critic of the fact that this has been a reason not to do imaging or not to do tests. The fact that doctors historically have been really bad at preventing patients from getting procedures they don't need is the reason why we don't get imaging, which just sounds ludicrous at face value. Absolutely. And I don't know if I have it all down correctly. So, but what if we could actually think critically about each thing that we find? Like, hey, this is a renal cyst. It's the Bosniak score is X. We should probably repeat it X time. We should probably take a look at some, renal function just to be certain. Hey, you have an adrenal gland lesion, right? We should consider doing some hormonal testing to see if that's active. Maybe repeat that scan, right? Not go in, cut out the adrenal gland, and then, and then say, what, imaging is terrible because 10% will have, an incidental finding. So how do you navigate this?
So, we I don't know if you guys have had a chance to do one of our scans, but we publish these, these reports after each scan.
We've done several scans, and even in Atlanta, we actually diagnosed a case of cancer and using a Prenuvo scan I guess you're in Atlanta, right? You're still in Atlanta?
That's right. Yeah.
Yeah.
Well, good.
Thank you for that. Thank you for helping our patients.
Absolutely. That is our absolute pleasure. 1 in 20 of our scans results in a high risk, potentially dangerous finding like cancer and aneurysm. But I tell all my patients, but 20 out of 20 scans is going to show you something that could be life-changing. That almost every scan I come out with, I can comment on something that's going to change your approach to your sinus health, your cardiovascular health. And that's when I'll dig into my preventative medicine core, morals, right? The things that we talk about with every patient. This helps us hammer those points even harder now because we have a scan to back it up. But going to your question, how do we deal with these questions of, the incidentals, and it's going to affect patient care, and we shouldn't do it because we're going to get those abnormal results, right? It's the question of the thyroid studies in South Korea. That South Korea did this nationwide approach to screening for papillary thyroid carcinoma, and they detected 30% more of the population than was being screened earlier to have positive lesions. And yet the end mortality never really improved with those patients, that they still had the same mortality rate from this nationwide screening process. And so that became this sort of like a cautionary tale that if you just do, a massive screening imaging protocol, that you may not actually come out with any better outcomes. We're finding the opposite at Prenuvo because of the way that we handle those results, that not every thyroid lesion may require a biopsy, and so it may not end up being something that is life-risking, life-changing. But we're using things like the AAFP guidelines, the American College of Radiology's guidelines. We reference those things in our reports because we want providers to feel equipped when they do these consults with their patients. Okay, the guidelines are right there. The patient's gotten a consult from one of our Prenuvo providers, and we do that complimentary for every patient. They get a 30-minute consultation with one of our nurse practitioners who's trained in our imaging, that we have communicated to them what we find is high risk and low risk, and we've based it on reference sources that are evidence-based guidelines to help them coordinate those next steps. But here's the real big message, and I hope that there's a lot of providers listening to this right now, that we have to remember that this is not doctor-centered care. This is patient-centered care. And if we avoid doing work just because it's going to create more work for us, then we really don't have our patient's best interest in mind. And that, I had a big debate. I was at the RSNA, the Radiology Society of America's conference here in Chicago this last week. And I debated this radiologist on the floor because he came up to us and he talked, about how Prenuvo is sort of throwing all these findings into the healthcare system and creating all this new expense. And I said to him, but if you did a scan for someone's chest and you incidentally found like a mass in their spine, you're going to work it up every time, 100% of the time. You're not going to ignore that incidental finding. That's just not how we're wired, that you're going to tackle it. Now, here we are, we're sort of flipping the paradigm that we are now looking for all the nooks and crannies in your body, and it gives us a platform to either pursue or not to pursue. But now we use clinical judgment. We are taking the time to use clinical judgment to make a clinically decisive decision with the patient, shared decision making. And if that patient goes off the rails and finds some guy in New Mexico to stick a needle in his eye, then that was going to happen, and that may not have anything to do with us. He was probably going to find that person anyway. But when you, the provider who knows the patient the best, can help guide and push that patient in the right direction, now we've got really something cooking, because this is what true personalized medicine has got to be about.
Yeah, and that's the problem too, is most of the radiologists these days don't know anything about, they're not reading the patient history. They're just looking at the scan, then they go, Absolutely. This could be a cyst or it could be lung cancer, and the patient freaks out. Then you get this huge, because everyone's doing CYA medicine, they don't want to miss something, so they overcall everything. So they go, clinical correlation recommended on everything, right? This could be something really bad.
Yeah. My favorite line on every radiology report I've ever read is follow up with your primary care doctor. Clinical correlation recommended.
Yeah.
Okay, well then if you're putting it back on me anyway, then first of all, the radiologists really don't have much to worry about that way. But the primary care providers, this goes back to sort of the beginning conversation that we had, that we are stretched thin in traditional primary care as is. And so we have to start to look at direct primary care, concierge medicine, telehealth, We have to start looking at the new tools that are out there in the marketplace to be able to deliver the quality of care that our patients are looking for and that they deserve. They really deserve this.
One of the things I've long thought of, is that the real problem here is insurance-based occurrence billing, right? So if I had an adrenal finding or a thyroid finding that was not clearly malignant and not clearly benign, what would I do? I would repeat imaging, and I would, maybe check for hormonally, if it's functionally, affecting me, right? So if it's an adrenal gland, maybe I'll check a renin, an aldosterone, a cortisol, right? You'll see if this thing is affecting me in any way. Is there any hint of this having an effect on my body, or is it just like a birthmark that's there and not doing anything? So the problem is the fact that not only is the patient incentivized to find out what that is to some degree, right? But because it gives them more agency over themselves, right? But the clinician is financially incentivized to go stick a needle in them. And so I think the real harm here is that we need to get docs outside of that system, right, of occurrence-based, procedure-based insurance. And that will solve the incidentaloma, issue, right? That will solve the, look, the study you mentioned, and I'd love to hear more studies like that, looking at thyroid screening across the population. Yeah, they diagnosed more thyroid cancer. Yes, there was no more mortality benefit, but like you addressed, we addressed an issue that could have been worse. I'm not convinced that that mortality is the only endpoint. What if that papillary thyroid, it's like there could be so many other endpoints that you can't quantify. So I think it comes back to individualized care. So just because it didn't, have a mortality endpoint doesn't mean that the testing shouldn't be considered. It just means that, hey, if we go in and do this systemically and we screen it systemically, we may not save lives. It doesn't mean individually the person in front of us won't benefit. So I have all problems with looking at medicine that way. And I'm curious to hear your thoughts and maybe other screenings that have been more favorable towards imaging or maybe less favorable towards imaging.
Absolutely. So, I'm really glad that you kind of put us on this trail because as I was alluding to earlier, the stuff that gets put on the billboards and the People magazine articles is the life-saving finds, right? I think James Vanderbeek's in the news right now because they've detected him having colon cancer, and it's shedding a lot of light on how young men need to get screened for colon cancer. But it's all the other things that we find on a whole body scan or a patient's biomarker screening that if we really start getting intuitive, we can start to extrapolate all these other health data points. And this is really important to the work that I'm doing at Prenuvo, is that only 2% of the studies that we'll end up reviewing will end up with a cancer diagnosis, but 100% of the studies that we review are going to find something really interesting or impactful to that patient's health. And when we start to sequentially monitor these scans over time, we start getting longitudinal data. We have a scan from last year, a scan from next year, and a scan 5 years from now. We can start to carry this thread across. And this is, to me, the basis of preventative medicine or proactive medicine, that once I see something trending in a negative direction, I can now intercept. I can make some really basic interventions here. This could be a simple change to sleep or nutrition or exercise or, the person's mindfulness and spirituality, that we can have those kinds of conversations before they hit the red line. Once they've hit the red line, I'm now dumping into the traditional medical system of, we're going to put you on 3 different medications. You're going to go see the surgeon, and this is going to now define your health for the next X number of years. So, an example of that is something I think you said Brian is really interested in, which is visceral fat. We've got this really interesting opportunity with a whole body MRI to start to really see visceral fat lighting up all over the body, and we can start to quantify that. And this is another exciting thing that my company is doing, is that we're implementing artificial intelligence to help us make those measurements and get really precise with the factors of incidence and then transitioning over time how those numbers are changing. Because again, right now, a radiologist would just read something and say, I think you have 25%, 30% visceral fat, whatever you. Now we're actually going to score your different organs. We're going to give you a fat percentage in your liver, a fat percentage in your pericardium, a fat percentage in your abdominal viscera. And once we have that baseline reading, the first conversation that they have with me is, how do I get that number down? And we talk about nutrition and exercise and all the other sedentary lifestyle factors that go into that, and alcohol consumption and things like that. And then they come in for their second scan, and either their number has stayed the same or gotten worse, which means, okay, now I need to get more aggressive with this person. And they're trying everything they can. Maybe they need help. Now I'm going to introduce the idea of a supplement. Now I'm going to introduce the idea of maybe a GLP-1 medication. And these medicines, by the way, I'm a big fan of. I don't know how you guys feel about them, but I think they're just so.
I was biting my tongue when you said Repatha, right? So. Yeah.
We try. I mean, in the right patients, the right time. But I think what we're seeing now is like everyone just says throw it on, and we're looking at 40 to 60% of the weight loss is muscle mass. Other long-term stuff we're looking at. So if we don't combine that with what you're doing with lifestyle, then you go, you're just buying time, and then you're going to be a disaster, even worse down the road. So a lot of people, I think, are using them inappropriately in people that want to lose 6 pounds, and they're like, oh, if we on a huge dose of this stuff, and they lose 6 pounds of muscle, and they're happy about that. So that's kind of our basic takes. Like, like you're saying, is like, if you see a lot of visceral fat, you're seeing fatty liver disease. I don't know what you're seeing with the GLP-1s from that standpoint, which may be interesting discussion, because if we can decrease visceral fat and fatty liver disease, we're going to be ahead of the game. And I think
they just published their fatty liver. They reduced fatty liver. It was like 90% actually reduction of fatty liver. I hate to give credit to the GLP-1 medications, but that's one area you could say that it did reduce it, Brian. But I'm with you 100%. Sorry, I didn't mean to interrupt you, Brian.
No. I mean, and this is like a really important debate that in my practice, we were throwing GLP-1s around like it was the next big thing. And then we had to slow down and actually look at the data of how people were losing body fat versus body mass. Were they losing muscle mass? Bone densities were going down in our older females. And so we had to sort of pause on that and say, are we really doing the correct communication around nutrition and exercise before we introduce that, and then while we introduce that medicine to help them? So that's one of the next important things that we're looking at now, is all these visceral fat, body fat. We just published at this conference in Chicago a paper that's now linking the condition of diabetes to cognitive or brain atrophy, cognitive decline and brain atrophy. And we're seeing that even in the absence of visceral fat. So this is a real puzzler, is that so far we've sort of made all these correlations that visceral fat increases is going to contribute to cognitive decline and brain atrophy over time. So it's a marker or a risk for dementia. But now we're seeing even people who have a stable BMI, and there could be people on their GLP-1 medications, unless their actual blood sugar, their glucose is under control, we're still going to have microvascular damage, and they're still going to see the cerebral atrophy happen. So it makes it that much more important that if you're on a GLP-1, you still got to eat the right stuff. You still got to exercise the right way and control that glucose index, that glycemic index, because GLP-1s don't necessarily fix that, right? They can make you look skinny, but I can't tell you how many patients I had who are skinny with an elevated A1C. So we still aren't quite fully there, that we're seeing the outside, but a scan like ours will show you the inside, what's really happening, and that's a really important piece of the puzzle.
Yeah, that's interesting data. That's interesting to me that you can have that. We see diabetic neuropathy before people actually get diagnosed with diabetes. There's certain things like that where you have certain pathologies that happen before you get the actual diagnosis, because it's a continuum. But that's interesting data. I'd be really interesting it's good that you're doing the imaging, following these people and seeing what's happening with their lean muscle mass, what's happening with their visceral fat over time, using these kind of interventions too. I think is really critically important, because when you can say, oh, you lost this much, or for our patients, they'll say, well, you haven't lost weight, but you put on 6 pounds of muscle, right? So your fat mass has come down, and you're metabolically healthier, even if your scale weight's not changing that much.
Absolutely, that we don't need to get so fixated on the number on the scale, that there are actually certain factors that we can look at that are going to give us a different demonstration of that patient's health. So yeah, these are studies that we are doing internally at Prenuvo. We just launched, this is a really big one. We just launched a study in Boston that will take us the next 10 years. And our hope is to enroll 100,000 patients across different socioeconomic categories. So we're trying to do this health equity based 100,000 patient trial. and start following these patients longitudinally, doing studies on them once every 1 or 2 years to really see how much change in their trajectory we can affect. And we feel very confident in that, but obviously we got to collect this data, because who needs to see the data? The evidence-based guidelines folks, the USPSTF, and the insurance companies need to see the data before they can really start digging into what we're doing and get on a payer basis. So until then, we're sort of stuck holding this really wonderful product that insurance doesn't see the benefits of paying for yet, but we're not going to withhold that option from patients because we still think that the costs and the benefits are there.
Yeah, I think that's a huge point, and then, I'm thinking about, it's like, if you can look and say your carotids look good, instead of doing 12 different studies, if you have one study that you can do, go, oh, you have fatty liver disease, your aorta looks good, this looks good. And so we get focused. And I think the other big benefit is people with a significant family history of ovarian cancer, pancreatic cancer. Those are very difficult tumors to pick up. And so if you go, I'm really concerned about it, like looking at tumor markers is not going to be, it's very non-specific a lot of the times.
Yeah, absolutely. 63% of those cancers, those true biopsies that we detected, were stage 1 or stage 2 diseases. So we are catching ovarian cancer at stage 1. We're catching pancreatic cancer stage 2, which is really unheard of in the world of those diseases, that you are unfortunately getting them at stage 3 and stage 4. Their 5-year prognosis is a dismal number, and they're pumping now hardcore radiation chemotherapy, just trying to save years. And now here is an opportunity for us to catch these things at stage 1. I mean, how do you, I just really get challenged with people who are argumentative about this opportunity. How do you put a value on that? What price tag is that worth to you to be able to save a person from, years of chemo and radiation, if we save them at all, and to catch it at stage 1, where it would be a simple procedure to just cut it out and then monitor them with serial imaging. So it's really just a change in the sort of paradigm that we're trying to argue about, that being proactive has all these incredible upside benefits to the patient's outcome and the patient's well-being. But we're making these decisions on population statistics, and we're making these decisions on cost analysis, which are flawed. The cost analysis program is a flawed system, usually the bias towards the payer not paying.
I think the other problem with looking at this data longitudinally over time is cancer rates have just consistently increased, right? So now, like, you're maybe you're having an impact, but the entire world's cancer rates are increasing.
Sure.
So and we're stuck to this timeline. We can't compare to a timeline that doesn't exist.
Well, and that's the problem we're in, is everyone wants to explain everything away. There's no question in my mind. I talk to oncologists all the time, and they're seeing a massive uptick in the last 2 years specifically. And so when you start seeing these things, you go, okay, now we start looking and we find it. They go, you're just seeing it now because you're looking more, right? You weren't screening like this before. Now that you have these fancy MRIs, now you're picking them up that you wouldn't have picked them up. They would still be there. And that's probably not true, but they'll try to argue it away that way, right? Now you're just detecting it more.
One that we get hit on a lot is our scans are pretty sensitive to degenerative disc disease, and that, I'd say almost 90-95% of the scans that we do is going to show some degree of cervical or lumbar degenerative disc. Mm-hmm. Okay. So in and of itself, that's like no duh, like we all have back issues. But now we're able to get these targeted images that will show you the degree of disc degeneration or the degree of disc desiccation. You're at 25%, you're at 50%. And it gives us a new opportunity to intervene with that patient's ergonomics, their posture, their weight management, their day-to-day exercise routines. Are they doing, the core exercises and the things that we know are going to make their paravertebral muscles stronger and slow that degenerative disc down? And the outcomes here are really staggering, that when we implement a program based off of these abnormal findings, we see a substantial drop in the patient's eventual necessity for pain medications, spine surgeries, these back injections, the cortisone injections, that our patients who go through our process are ending up doing just physical therapy and really dedicated, conservative treatments. And, we talked about turmeric and we talked about anti-inflammatory diets. That, I can't put a dollar value on that. I can't say how much money I saved your company by implementing that, because I can't prove to you the timeline that never happened. But I can see it in my patients' faces, I can see that, they watch their mom and dad get really sick and have these back issues, and they themselves are now proactive in beating the system.
The problem when you're dealing with an intervention like this is you're going to find more problems.
Yeah.
And so you're being penalized for doing good work, right? And so if you're trying to prove a cost-effective model, it's never going to work out for people who are looking to do a better job, right? So it's never going to work. You're going to find more things. So this is the problem with showing cost-effectiveness. And then on the flip side, I think what you mentioned was that outcomes is absolutely needed. You need that 100,000 patient outcome study. I mean, that's the gold standard, really. But the problem becomes is, okay, what if we just gave them all that counseling and had none of the tech, right? How much is fear from finding something motivating that patient, right? How much is the anxiety of knowing?
I think when you see something, Tro, you go, crap, I got this fatty liver. I got to do something. I see it. I know it's there now. Otherwise, you're living in this fantasy world. Like, I can drink my soda and I'm fine. And once you go, you got something that it's there, right?
Brian, I could tell somebody, hey, look, you got visceral fat by looking at their neck and looking at their weight.
Yeah, I know. But when you could possibly be wrong, but they go, it is there. That is there. We need to do something. Like, I'm telling you, I think people are, when you got something, you go, oh, gosh. And when we have interventions that we could do something about, like, don't forget 2 years ago, the American Diabetes Association, their definition was chronic progressive disease, no cure. Basically, you got it. Now we say, well, we can reverse it, or at least put it into permanent remission, whatever you want to call it. And so we're seeing people. I just talked to a guy yesterday. He goes, I did this crazy keto thing and all my knee and back pain went away. I'm like, yeah, you decreased your inflammation. You did the right thing. Look, and I could explain. He didn't even know why he did it. Now he's like, oh, that's why my blood pressure, and I got stopped 3 medicines. Yeah, you dropped your insulin. Now you can eat salt, and these kind of things when you see it is so exciting, and they're telling everyone, all right, because they're excited about it. So I think when you know something for sure, like if someone tells you, if you take your car and they go, look, here's your fan belt, it's about to break, it's 80% cut. Instead of saying, oh, it's been like so many miles, you should probably check it. No, like if you go, it's going to blow on you. You go, okay, fix it. I'm not messing. I don't want to mess with it. I'm going to be stuck in the middle of the desert somewhere.
Saying the fear, I think that there's this knowledge and fear mixture, right, with testing, but what if we what if we could be so motivating as a profession, and what if we could be so crystal clear about our messaging that, hey, look, you're going to get tech neck if you don't get, chair, standing desk, all the ergonomics that, Vikash, you just mentioned, right? What if we just did that? What if we actually just did that? We know what affects our society. You look around, the rate of cervical spinal disease is through the roof. The rate of visceral fat, liver fat is like nearly ubiquitous. It's happening in 12-year-old kids. So I wonder, the fact that we need MRIs, I think, is another testament to how terrible we have done, right? How terrible we have done at prevention. That's my,
So I just have another question. Like, so if one of my female patients she's worried about breast cancer, she goes in and gets the whole body MRI. Can I say that's a better screening than mammo, or it's equivalent?
No, so that's a great question. No, there are certain conditions where we still stick to the USPSTF guidelines. And so in the case of like a screening Prenuvo scan, it's not a diagnostic MRI. We're not using IV contrast. We don't have a dedicated breast coil. If you ever seen someone do a breast MRI, they have to flip over on the bed and go supine versus prone to get that full diagnostic imaging. So we're not doing all those sequences and protocols. In order for us to maintain this sort of like under an hour screening process that we do, we have to streamline all these sequences. And so right now, we're not at the level of diagnostic MRI. So right there on the front of our website, right there in our report, right there in our consultations, we say to the patient, you have dense breast tissue. Our scan didn't detect any lesions, but for best safety, you still need to get that dedicated MRI, ultrasound, mammogram, whatever the patient's qualified for. So we put that out there. Same things, lung screening, that we don't take the place of a CT lung scan, a low-dose CT for smokers. We certainly don't take the place of like a dermatological exam. You'd be surprised how many folks get upset that we couldn't comment on their skin moles. But, sorry, guys, MRI does what it does. And then things like cervical cancer and pap smears, that's such a critical thing. Colon testing and colonoscopies and Cologuard tests, those are still so critically important because we don't want to be giving people a false sense of security when they get a negative MRI, that there's no absolute potential for cellular disease developing that early stage. And that's, again, this industry is evolving so much right now that we're looking at multi-cancer early detection tests in combination with what we're doing. And we've seen the risk then of being assessed at less than 1% when you can match like your Gallery test with a Prenuvo scan, or we can match, your mammogram, colonoscopy, dermatology exams with a Prenuvo scan. Then we see your absolute risk being significantly lower. Until those boxes are checked, though, we're still, I think the percentage I saw was about 14% of cancers are detected by routine screening pathways. That means 86% of cancers are being missed until they're later diagnosed, right? They're not being caught in that early screening. So here, that's the space that we want to live in, is this 86% of other disease, of cancers in particular, but all these other diseases which don't even have, prevalence numbers like that, that aren't being detected until they're full late stage diabetes or they're full late stage heart disease and they're getting a stent and a bypass. We're taking this opportunity to intervene early. And well, again, I shouldn't even use heart disease because we don't look at coronary angiogram, right? We're not a coronary test. We're looking at the size and the structure of the heart, but you still need to get something like a CT angiogram and your lipoprotein testing done if you really want a good sense of your cardiovascular disease. So we're trying to be very upfront with what our tests can and cannot do. I think to Tro's point earlier, should we be doing a better job of just, announcing prevention and being proactive and communicating these needs to our patients? Yes. But I'm far enough in my career, I don't know where you guys are, I'm far enough in my career to also know that people do what they do and they hear what they hear, and it's not their problem until it's their problem. And that's just sort of like with health, it just seems to be the sad reality, is that yes, you're going to have a percentage of patients who are just very proactive. They're going to take everything that you say, like it's, the speech from on the high on the mountain there, and they're going to take it and say, yes, I'm going to do everything you just told me to do. Fantastic. But for most other patients, it's like, it's not broken, don't fix it. And that's where something like an MRI, a black and white picture that shows you, I'm sorry, but it is breaking, that you're probably about 5 years out from having a major degenerative disc issue, or you're probably about 5 years out from having a major liver issue, that you need to be proactive now before you're too far gone. Unfortunately, patients need to see that data. We're in a data-driven world. People are wearing trackables and their wearables, and they want to know what their heart rate and their pulse rate and their blood pressure and their pulse ox is. People are tracking all this data, and we're now getting into such a granular world where I think that people appreciate the data points, but it has to be managed so carefully that if you just dump a bunch of data on a patient without context, without guidance, then it becomes overwhelming and useless. And so that's really,
it's another tool that has to be used the right way. CGM is not helpful if you don't know how to manage the sugars, right?
Absolutely.
And so you're just going to throw a drug at everything. So patients are going to ask me now, how much does it cost, like for an average person to come in and just do a complete scan?
Sure. Yeah. So, we offer 3 different types. Our marquee test is the whole body MRI, which is from your head to your ankles. And that costs about $2,500 right now. And obviously there's promotion codes and discount codes. Hopefully we've given your listeners one of those. If not, please talk to me afterwards and we'll get one for you. So there's always going to be some sort of like a discount or a benefit there. And then we also have like just the head and torso scan, and then we have just a torso scan. So people can kind of choose if there's an important segment that they want to scan, if there's, a big region that they want to scan, or if they want to just do the whole body proactively. So, when you check out our website, we have those 3 different price tiers listed. And, we're in research and development, and we're looking at the way that technology is evolving, that the scan time is going to get shorter. That, about 4 or 5 years ago, this scan took 90 minutes, an hour and a half. And we got it down to less than about 55 minutes right now. So the machines are getting faster, and the AI is helping us to collect those images. We still have board-certified radiologists reading all of these, and that takes a piece of time. But we're usually able to turn the scans around within 5 to 10 business days. So as the scans are getting faster, the equipment's getting cheaper, we're going to see the adjustment in price coming down. But then you've got me, the preventative medicine guy, and I'm thinking to myself, well, for the same amount of time, what other new data can I collect? Can I start to implement something on body composition? Can I implement something on neuroquantification? That's one of our new pet projects internally, is starting to just measure brain volumes and different volumetrics of different regions over time. And then another big key piece for me is cardiovascular health, that at this current place in time, a whole body MRI just really doesn't have a great way to comment on coronary arteries. But technology is evolving. In the next 6 to 8 months, we're going to have a new option there to start looking with a non-contrast MRI at people's heart health.
Awesome. Yeah, it's great keeping up with the technology. And I think a lot of people go, hey, it's worth it. If you're
Absolutely.
a CEO somewhere, you're like, you know what? I spent a lot of dumb money on other stuff, and just to make sure and get the peace of mind.
Well, no,
Yeah.
I think it becomes a really great, that's sort of like our marketing push right now is that this is a great gift to give for the holidays. And, marketing aside, I honestly believe that this is something that I've gotten from my family members. I've encouraged my friends and colleagues to come and get one of these scans because I firmly believe that the information that we learn and the context that we can put it in when you match it with things that like your clinics are doing with biomarkers and lab tests and lifestyle interventions, I just think that that there's no end to the potential outcomes here being beneficial. That in 10 different ways we can affect somebody's positive outcome, and to me the long-term price way outweighs the benefits that we're talking about here. That the price is a dismal drop in the bucket compared to the benefits that we're going to be able to show our patients.
I think,
It is.
I think that as also time goes on, I mean, we're seeing what's happening in the space, right? We're seeing that breast MRI is now commonplace, right? More and more accepted. Prostate MRI is more accepted. If you have cerebral aneurysms in your family, that's more accepted. Doing MRI, if you have a family history of pancreatic cancer, that's more accepted. So I think, what's going to happen is things are going to coalesce in the next 5 to 10 years. And I look forward to all the data you guys are producing, and maybe you can share some studies that we can include in the show notes, and I'll put that there. I just want to say thank you. I know Brian's got one question, but thank you for coming on and educating us and telling us more about this.
Yeah, no, I appreciate it. Yeah, thanks so much. Great education. And, I think it's nice if someone's really concerned, go, okay, look, here's something you can do. Here's how much it costs. You can do it or not, right? And then, I was wondering, do you have dedicated testing centers, and are they all over the U.S., or do you go through like other existing imaging places, then you do your service through them?
Our approach is to own the whole thing completely vertically. So it's our test centers. We don't like license this out to partner clinics or whatever it is. That when you go into one of our facilities, it's 100% our training with the front desk. It's 100% our facility, our technology. So it's our hardware that we're not building the hardware, but we've partnered with manufacturers like Philips and Siemens to get this very specified hardware built that specifies with our software. And then again, it's our board certified trained radiologists who are reading every report. So it's a very uniform experience. And right now we're in about 17 locations in North America. We've just opened clinics, like I said, in Boston. I'm here in Atlanta. We just opened Scottsdale, Arizona, and Denver, Colorado. And we hope to actually hit about maybe 25 to 30 clinics by the end of next year. So our footprint is expanding, and we're coming to kind of markets closer to everybody who may be listening right now. Our other site is set now on international expansion, that we want to bring these services to London, to Australia. So we're going to be looking at doing some more international work, and that's a whole different landscape for healthcare and healthcare expenses. But we're starting to make our way in there. But it's such an exciting time to be in this, because I do think, Tro, to your point, that yes, getting in now and understanding this technology now is going to put us way further ahead when the guidelines maybe hit in 5 or 10 years and the evidence comes to support what we're doing. We'll already be firmly established and have been doing this for years by the time we get there.
Yeah, listen, if you need a director of metabolic health, you let me know.
I got you. I got your name. I got you.
Yeah, I'm not far from Scottsdale.
All right. Let's go, guys.
All right, guys.
So awesome stuff.
Dr. Modi, thank you so much. Brian, it's always a pleasure. Maybe Dr. Modi, if people want to find you or find more research on Prenuvo, maybe we can put all the links in the show notes. And
absolutely.
There's a way for clinicians to reach out. I'm sure you'll give us everything, and we'll throw it in the show notes.
No, perfect. Yeah, I mean, Prenuvo.com, we actually have a research page on our website, so people can see all of our up-to-date research that we published on that link, Prenuvo.com. And then if people just want to follow me and hit me up, I'm on Instagram at Doc Modi, DocModi on Instagram.
Doc Modi, I'm going to go follow you now.
Get at it.
Yeah.
All right.
Awesome, Doc. Thanks so much for joining us.
All right, fellas. You take care now. Thanks so much for the opportunity.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.